All right. Welcome, everyone. My name is JC. I'm one of the third-year Emerge residents in the FR program. I prepared this presentation supervised by Dr. Mathieu Gatien. And what we'll be talking today about is tranexamic acid and its use in the emergency department. So what I have planned for us today is to go over a basic outline, basic background and basic pharmacology of tranexamic acid. And then we'll dive right into possible indications for its use. Now, as I'm sure you've expected, the biggest portion of this talk will be about trauma, easily 50% of it. And then it'll be followed by isolated TBIs, epistaxis, GI bleeds, and in menstrual bleeding. And really what I want for all of you to walk away with after this talk is, when it comes to trauma, it's really tranexamic acid. How do you use it and when? And in traumatic brain injuries, epistaxis, and in GI bleeds, I want you to have an appreciation of the literature that has been done on these indications and whether you can use it in your patients in an evidence-based way. Lastly, with menstrual bleeding, again, how to use it and in what patient population. Let's start with background. So, the clotting, in terms of there's a homeostasis in terms of your clotting pathways. In medical school, it's almost taught as a linear point A to point B, but everybody here knows that it's really a balance. You're balancing your clot formation with some clot breakdown. And logically speaking, it's so that the clot doesn't extend past the site of endothelial damage. So this is always in flux. And clot breakdown is, of course, known as fibrinolysis. And I want you to think of plasmin as what breaks down clot. So think of it as this clot-eating monster that just wants to eat clot. And unfortunately, it has a muzzle. So when it has that muzzle, it's plasminogen, and it's really angry. It wants to eat some clot. So what it needs is that knife. So up there, that's the TPA, or plasminogen activator, which is going to activate the plasminogen into plasmin, and plasmin is going to eat that clot. Make sense? So, where does tranexamic acid fit into all this? One, it's a fibrinolytic, okay? And it's a synthetic analog to lysine. And so what it does is it actually prevents the breakdown of clot by plasmin. And it does so by inhibiting the lysine site. So the black square is tranexamic acid. It's bound to the lysine site on both plasminogen and plasmin, which prevents its conversion, and it prevents plasmin from actually binding to the clot to break it down. So the monster can't satiate its appetite. Milestones in terms of dates. TXA is definitely an old drug, okay? First described in 1966, and it had its first clinical trial in menorrhagia in 1968. The FDA approved its IV formulation in use pre-dental extraction in hemophilia patients. And in 2009, it was approved for menstrual bleeding by PO. As I've alluded to, there are two formulations. There's the 1 gram ampules IV and the PO tabs that come in 500 milligrams. From a pharmacy perspective here at the TOH, the ampules contain 1 gram or 10 cc's of TXA. And they're cheap. They cost less than 2 coffees from Starbucks. And they're always in stock in the Omnicells in recess on both campuses. I think at the Civic there are a minimum of 11, at the General a minimum of 5. And according to my pharmacist friend, most of pharmacists are open to off-label uses, if ever you feel adventurous. In terms of adverse events, the most common adverse event is mild GI disturbances, so nausea, vomiting, diarrhea, usually not severe, and resolves actually quite quickly. Now in the literature, and still considered adverse events, it's a visual disturbances. So they have shown an increased incidence of blurry vision and loss of color vision. But I have to say it's very questionable as to how real this is. And in seizures have been described in small retrospective reviews, but you have to know that the doses they used in these studies were a lot bigger than what we use today. We're talking about 7-10-fold increase in dose. And hypotension can happen if you push the IV dosed too quickly. So there are not many contraindications to tranexamic acid, actually. Hypersensitivity, of course, is one. The acquired defective color vision is listed, but again, the only reason is because if you have color blindness before the drug, they cannot follow your color vision in terms of toxicity. So that's why it's been listed historically, but it's, again, put into question. Subarachnoid hemorrhages actually have been a contraindications for a while in tranexamic acid. And that's because in some small observational studies, patients that received tranexamic acid had increased risk of ischemic lesions. They thought it was because of vasospasm. But right now in the United States, they use another antifibrinolytic, aminocaproic acid, very often in their spontaneous subarachnoids. And other literature have shown that it's not, this concern may not actually be real. Lastly, hypercoagulable states. We'll talk a bit more about this in the menstrual bleeding portion, but patients with factor V Leiden, with history of thrombosis, exert caution, but that's, again, not evidence-based, and we'll talk more about it. Let's dive right into it. Trauma. So trauma is a significant cause of early morbidity and mortality. And a normal response to trauma, or even surgery, is fibrinolysis. Again, so that the clot doesn't extend past the site of endothelial damage. However, in a small portion of trauma patients, so 5 to 10%, this normal response can become pathological, where lysis completely outweighs clot formation. And what happens is the clot is not stable, more bleeding in these patients. And the mortality increases dramatically, between 50 to 100% in the literature. So small proportion of your trauma patients, but higher mortality. And there is strong surgical literature that if you give antifibrinolytics pre-op in elective surgeries, so hip, knee replacements, there was a huge systematic review. It decreases the amount of blood transfusions that patients need by a third, and it decreases the amount of packed red cells they need by a unit. So they thought, you know what, it works in surgery, why wouldn't it work in trauma? And this was the case I sent to you in the surveys. Again, thank you so much for answering. Huge amount of responses. I'm very happy with that. The case is a 45-year-old male who comes in, MVC an hour ago, tachycardic, hypotensive, and FAST is positive. I asked if you would add tranexamic acid to your management. 95% of residents said that they would. And this compares to the staff response of more around 80-20. And I've actually noticed that working in the emerge or working off service, that tranexamic acid is not actually still not on the forefront of everybody's mind during a busy trauma resuscitation. And that's one of the reasons why I decided to talk about this. So let's talk about the big trial that started it all. So it's the CRASH-2 trial, done by a ton of people, labeled under the CRASH-2 collaborators. It was published in The Lancet in 2010. And it was a very robust study. It was randomized. It was a randomized control study, double-blind, intention to treat. They did all the right things, spanned across 274 hospitals and 40 countries. And they randomized 20,200 patients to either receive tranexamic acid or placebo. I know we know this literature quite well, but it's important to go over it because there is still controversy behind it. So the dosing that they used, of course, is 1 gram over 10 minutes and then another gram transfused, or infused, I should say, over 8 hours. And they included adult trauma patients presenting within 8 hours of injury. And these patients had to have significant signs of significant hemorrhage, so systolic blood pressure of less than 90 or a heart rate of over 110, or, and this is a bit more of the subjective inclusion, at risk of severe hemorrhage or shock by the treating physician. Now, I think that's very realistic. You see somebody bleeding, they're compensating really quite well. You think they might need to be transfused later on. These patients receive tranexamic acid. So it made sense to me. And this is taken straight out of the protocol, and this is a point of contention for critics of the CRASH-2 trial. It's based on the uncertainty principle, and it essentially states patients were included if the responsible doctor was substantially uncertain about whether or not to treat with TXA. So they excluded people that the treating physician believed definitely needed TXA, and they excluded patients that thought TXA was contraindicated. Listening to podcasts and reading forums, it's obvious that lots of people have actually misunderstood what this means. People thought that they excluded sick patients because if somebody's bleeding a ton, they are indicated to receive TXA. That's not the case. People, first of all, only 14 patients were excluded. And that wasn't provided in the main paper. But after a while, and after talking to one of the collaborators, they only excluded 14 patients, which is pretty good, out of 20,000. And they excluded patients that were hemophilia patients. That's what they meant. Like people, not hemophilia only, but with some kind of bleeding disorder that they believed it was unethical to withhold tranexamic acid, and they needed all the help they can get. So keep that in mind. They looked at primary outcome of all-cause mortality in a month, and important secondary outcomes included vascular occlusive events, surgical interventions, and receipt of blood transfusions. And these are the results. So as you can see, they divided them into subgroups by time, blood pressure, GCS. And if you look at the time, as the signal of benefit is higher in the patients that were treated within 3 hours. Afterwards, it was kind of all over the map. You couldn't really make much of it. And you can also see that it seemed to benefit the sicker patients, the patients with a blood pressure of less than 75, more. And overall, the risk ratio was 0.91 with a nice tight confidence interval, favoring patients that received tranexamic acid. So all-cause mortality was 14.5 in the tranexamic acid group compared to 16 in the placebo, for an absolute risk reduction of 1.5 and a number needed to treat of 67. It's a real statistically significant benefit, but it is a modest benefit. In terms of thrombosis, no statistically significant result difference. If anything, it trended lower in the TXA group. And if you look at the subgroups, there was actually a statistically significant lower rate of MIs in TXA compared to placebo. And this was one of the interesting results. So their primary hypothesis was, TXA is an antifibrinolytic, it'll stabilize clot, so bleeding should be reduced. However, the blood transfusion rates were essentially equivalent in both arms. Now, this can be explained by one of two things. Either there's a survivorship bias where the TXA group was able to survive more, so received more blood. That's a possibility. But also it could be that there's a secondary mechanism at work. Now, something I did not tell you is that plasmin is also a pro-inflammatory. So if you prevent conversion of plasminogen to plasmin, you might be reducing the overall inflammation, which is where you might see your benefit. Another interesting thing about this is the fact that only 50% of patients received blood transfusions. No, it's okay, we fixed it. Thank you. Only 50% of patients received transfusions, and only 50% of them had surgical interventions. So not a lot of people were sick, right? That's another point that people bring up. But I would argue that that actually brought a conservative bias to their study, where it actually lowered their perceived treatment effect. A year later, in 2011, published in The Lancet, they did an exploratory analysis of their CRASH-2 cohort. So the main study looked at all-cause death, but here they're looking at death by bleeding. These are the results. The first column, ignore it. That's essentially the results from the main study. Bleeding death is the interesting bit. So the first row is the overall risk ratio, which was statistically significant. However, when you break it down by timing subgroup, nice 0.68 within an hour, good risk ratio here between 1 and 3 hours. But patients were actually at increased risk of death if given TXA after 3 hours. Why? I can't explain it to you, but that is what it showed. And obviously with these results, with these subgroups, these results are not homogeneous. So you cannot use the overall risk ratio that they provided of 0.85. For those that like more of a visual, look up at the top. You'll see that within 3 hours, strong signal for benefit, and after 3 hours, strong signal for harm. And again, it seems to imply that the sicker patients seem to do better, seem to gain more of the benefit from TXA. The overall bleeding death absolute risk reduction was 0.8% when you received TXA. In my opinion, the CRASH-2 study is a great study. Okay, it's one of the best that we have in emergency medicine. That's my opinion. Now, however, there are some limitations. Okay, totally fair. there is a wide variety of hospital settings. So only 13% of patients that were randomized ended up being in centers that are kind of comparable to ours, North America, Europe, and Australia. 13, kind of low. But considering that they set up this very pragmatic, huge study that has good external validity by using these kinds of broad inclusion criteria, you would hope that the generalizability would come out in the wash after all this was said and done. Again, subjective inclusion criteria and a large number of patients were not severely injured. Again, I think this is a realistic kind of setting. They're not trying to explain how or if tranexamic acid works. They're trying to show that tranexamic acid helps patients. And I think that's what we care about as emergency physicians. Indeed, there is no data on injury severity or coagulation, but honestly speaking, injury severity scores are done in retrospect, so it doesn't actually affect our practical approach to these patients. It would have just been maybe nice information to have. Bottom line, there is a modest benefit with a number needed to treat of 67. And people might kind of scoff at 1.5%, but honestly, if we expected a 20% difference, I think we would have known by now that tranexamic acid works. So this is what we were looking for. Give it early, give it in patients less than 3 hours, be careful after that. No increase in thromboembolic events in TXA. A year later, the Matters 1 trial came out, and this was a study done by Morrison and colleagues called The Military Application of Tranexamic Acid in Trauma Emergency Resuscitation, published in JAMA of Surgery in 2012. And this was a retrospective observational study taking place in a Role 3 surgical hospital in southern Afghanistan, in Camp Bastion. So a very unique kind of setting. And they looked at trauma patients, war trauma patients, that received at least 1 unit of packed cells in 24 hours. So all of their patients received blood. They ended up looking at 300 that received TXA and 600 that did not receive tranexamic acid. And the way they did that is that this is essentially a pre-post observational study where these 600 patients were prior to the CRASH 2 trial coming out, prior to them implementing TXA, and the 300 were after. They also did a subgroup analysis of patients that received massive transfusion protocol, which was defined as over 10 units in 24 hours. The mortality, so they looked at mortality at 24, 48 hours, and at 30 days, and they again looked at thrombosis, transfusion requirements. They said that they would look at timing, but they actually didn't. And the results showed this. The baseline characteristics of the patients were not the same. So the TXA group was actually quite a bit sicker than the no TXA group. As you can see, the injury severity score was higher. The GCS had a higher incidence of being low in the TXA group, and their blood pressure tended to be lower. In the massive transfusion subgroup, though, they were equally sick. So this were actually, you know what, I'll talk about that later. And despite the tranexamic acid group being more sick, they seem to benefit from tranexamic acid with higher survival rates. So look on the left, this is the overall cohort, and you will see on the Kaplan-Meier curve, the dotted line is the other patients that received TXA compared to the bottom line, which is the ones that did not. There was a survival benefit, an absolute risk reduction of 6.5% and a number needed to treat of 15, which was statistically significant. And this is despite them being sicker. Now, if you look at the massive transfusion subgroups, again, these patients were understandably equally sick when you look at that MT subgroup, and they seem to benefit even more. So the absolute risk reduction was 13.7% with a number needed to treat of 7, and that was statistically significant as well. One thing I do want you to note, however, the Kaplan-Meier curve seemed to be parallel with before 48 hours. So you would expect patients that die of bleeding usually die within 48 hours. So if the benefit was only from the antifibrinolytic aspect of TXA, you would expect the benefit to precede that. And we don't see that here so maybe it is a bit of the anti-inflammatory as well. In terms of co-interventions, the tranexamic acid arm did receive more blood products, and that's likely because the tranexamic acid arm was sicker. However, one thing that's reassuring, one of the big co-interventions that can muddy up the results is FFPs, and the ratio of FFPs were equivalent in both arms. Massive transfusions, very similar in terms of their transfusion requirements. Secondary outcomes, the VTE, so the venothromboembolic events were higher in the tranexamic acid group. And, again, number one, too small a study to actually pinpoint TXA as the individual risk factor. Number two, the tranexamic acid group was sicker, so at higher risk of thrombosis. And three, because there was such a high survival benefit, they likely had the chance to survive long enough to experience the wonderfulness of a clot in their legs or in their lungs. So they were able to survive to that point. And if it's reassuring to anybody, none of them died from these clots, which is fantastic. So, limitations of the Matters 1 study. Observational study, and it is in a unique setting. Timing is unfortunately not reported, and considering that timing was so important in the CRASH 2, that's a bit of a limitation there. There actually was no clear tranexamic acid protocol in the first year that they implemented TXA. So there might have been some selection bias in that time. I cannot confirm that. And again, there were some imbalances at baseline. Bottom line, it provides additional but imperfect data. There's a higher mortality benefit in the severely injured patients, and the tranexamic acid group again had increased survival despite being the sicker cohort. In terms of trauma, some studies to look forward to in terms about TXA. There's the PATCH trial being run in Australia. It's a pre-hospital study, land pre-hospital study, where they're going to look at, I think, 1,000 or 1,500 sick patients. So they're going to look at the people that need blood, that look sick. They're using a COAST. It's called a COAST kind of scoring, and their results will be interesting because it's very related to our kind of setting. There's also the STAMP trial, which is more of an aeromedical study, looking at sick patients again, and it's coming out of somewhere in the States. So look forward to those. My bottom line for tranexamic acid in trauma. It's a cheap drug. Okay? Cheap drug. There is sufficient evidence, in my opinion, and there's low enough harm to do it, and just give it. So I would give it. And honestly, we do a lot worse things with a lot less evidence, and yet we're being very picky about this. It drives me, I don't understand it. And I would love to, we'll be discussing it a little bit later, but it's interesting as to why we don't do it. Think about TPA and strokes, and think about next time you call a stroke code, you're doing something that could cause a lot more harm with a lot less evidence, right? Again, giving your patients if they present less than 3 hours from injury. And just as a rule of thumb, so it becomes kind of like a knee-jerk reflex, because that's what I need, right? I don't have very much space in my brain. So if I'm going to order a unit of packed cells, then I'm going to order tranexamic acid. But your threshold technically should be lower than that. It should be if you order kind of a type and screen or a cross-match. Unfortunately, the nurses do that for us, so that might not be enough of an indicator. So if you think a patient might need blood down the line within 24 hours, you have a narrow window to give TXA, so I would give TXA. So I was lazy, and I actually just did a survey. There was a second-year medical student that actually did some hard work with Dr. Lampron and Dr. Wu, KDL, and unfortunately she couldn't come today. She did a retrospective study on how we're doing here at the TOH. She included patients that presented within 8 hours of injury and required at least 1 unit of packed cells, which is quite appropriate, and we'll talk about the timing a bit later. 62% of patients that presented received TXA, and only 50% of patients received the complete infusion dose. So again, we're giving it to 2/3 of the patients. So Monica Ott did a study in 2011, and again, the inclusion criteria of the two studies were a bit different, so it's hard to compare. But there probably is an improvement. Now, my question to Katie was, 62% gave the bolus when they presented within 8 hours, but I was wondering how many physicians thought that, you know what, after 3 hours I might cause them harm, so I will not give it. So poor girl, I made her go back into the entire data, and she went through the patients that presented within 3 hours, and it turns out that still 2/3 only got it. So that's 66%. There was barely a difference, so it didn't really factor into this all that much. So there's still a third that are either forgetting or choosing not to give it. Bottom line, probably improving, and the adherence to the CRASH 2 dosing isn't great, and I'm hoping this talk will change that just a little bit. And this is probably why it's not doing so well. This is the best that they have in terms of promoting TX. Yeah, it's really their song.
Save my life today.
Oh, doctor.
Give me Tranexamic Acid.
Oh, my doctor.
Crash bleeding. Give me Tranexamic Acid for my car crash.
You know, you guys laugh, but it's actually really catchy. I caught myself singing this song many times in the shower. Anyways, so that's enough because I'm kind of limited on time. We do have some time for discussion. Questions, comments, compliments, something. Anything? No? Okay, well, you know what? We can open it. Dr. Vaillancourt.
No doubt it's a big study, and they found statistically and arguably clinically improvement in death. Just wondering if before knowing the results, that all people would ask them, what would be clinically relevant you hope to see before you would adopt the behavior of using acid? Certainly in disease like cardiovascular survival is 4, 5, 6% survival to begin with. An improvement in 1%. That's our MCI. That's our minimum relevant. In trauma, where your survival rate is 80, 70%, I wonder if 1.5% survival increment is something that people would be looking for really before they would jump on everybody. Or if you ask people ahead of time, if you wouldn't have to receive nothing more, maybe, well, I need at least a 5%. I'm wondering if you look at it this way, if your results are becoming as relevant.
So for the people listening elsewhere, Dr. Vaillancourt used very big words, and I'm just going to summarize it. Essentially, he is wondering if, with trauma being, the survival rate being so high, up to 80%, if a 1.5% absolute difference, being so modest, would actually make a difference. And that's totally fair. I understand that. But at the same time, what is the harm? It doesn't actually prevent... everything we do in medicine is kind of cost-benefit. And if you're going to give that 1 in 67 people a chance to survive, why not? To my question is really why not? That's really where I'm coming. And it's fair. I can't argue it. It's a small benefit. And sometimes you do not know who ends up coming in really sick. So patients that were sicker seem to do better. We don't know in the emergency department in our first 5 minutes who is going to go down that line of being really crappy down the road. So to me, cost-benefit, it's worth it. And at least it's cheap. 2 Starbucks cups of coffee cost more. Absolutely. Anything else? Yeah. Yeah, absolutely. So lots of people think that TXA is a fad, kind of like corticosteroids and spinal trauma and whatnot. Maybe. We'll see. There are lots of big studies coming up. So we will know for more sure in about 3 years. There are more studies coming up in different indications. We will see. Anything else? Hopefully we'll have time at the end to talk a bit more. We're good? Yes. Yeah. Perfect. So we're going to talk about that next. Fantastic. Right now, actually, we'll talk about that. So let's move on to isolated traumatic brain injuries. This was the case I presented to you in the survey. 30-year-old male, mountain biking for some reason without a helmet. It's a fake kind of scenario. It doesn't really make sense. Had a low GCS, found to have a right-sided subdural and lots of bleeds. Who would give TXA? I was actually kind of surprised by the results. It's kind of a 50-50 split. I'm not sure if it's because of the crash 3. I meant who would actually use it. But I understand why. These are bleeds that are not compressible. You feel pretty useless with them. So, you're trying to help the patient bleed a bit less. But let's see if any of it is evidence-based. So there are 2 RCTs out there that begin to explore this, and we will talk about them today. There was a nested study in the CRASH-2 trial where they took 200 of their 70 patients that also had a traumatic brain injury on their pre-randomization scan. And these patients received a follow-up scan in 24 to 48 hours. And what they found was that there was a, excuse me. Hello? Yes, you do. Thank you. Wrong number. So there was a statistically insignificant difference in terms of internal hemorrhage growth. 6 milliliters in the TXA group compared to 8. There was no significant difference between new focal ischemic lesions. So remember the vasospasm issue? That's what they wanted to look at as well. No difference. And in terms of all-cause mortality, no statistical difference. But remember one thing, tiny, tiny nested study. Lots of patients had extracranial hemorrhages. So really limited in terms of what you can draw from this. And there was this study done by Yutha Kasimus, Dr. Venk's cousin, and it's called Tranexamic Acid for preventing progressive intracranial hemorrhage in adults and with traumatic brain injury. Stop it. It was a randomized control trial, double-blinded, placebo-controlled. I'm not sure if I said that. Published in the BMC Emergency Medicine 2013. And they took 238 trauma patients with moderate to severe isolated TBI, and they tried not to, and they did not include patients with significant extracranial bleeds. Again, I kind of summarized it really short. It's a very small study, so the results weren't great. There was no increase in progressive, no statistically significant increase in progressive ICH. They defined that by either a new bleed that was not seen in their first scan or an increase in the size of the bleed by 25%. And there was no statistically significant reduction in mortality. Bottom line for these two trials kind of lumped together, there is potential, but not much else can be said. Too small, too little data. There is no data on TXA with disability, and it needs more evidence. So, do you guys know who this is? Yeah, this is the Tran man from CRASH-2. So he's going to come to the rescue and then bring about the CRASH-3. By the way, never Google Tran man. No, really, it does not bring the results that you want. Google CRASH-2 man, tranexamic acid man, Tran man is not a good search. So the CRASH-3 trial, tranexamic acid for the treatment of significant traumatic brain injury. Very similar, I'm not going to go through it, but very similar kind of design as the CRASH-2. Randomized, double-blind, multi-center. They're looking to recruit 10,000 patients, and we are one of the centers. They will randomize patients that were diagnosed with a traumatic brain injury on a CT scan or with a GCS of less than 12, or 12 or less, I should say, if CT scan is not available at that moment in time. They're looking to not include significant extracranial bleeds, and patients should present within 8 hours of injury. They're going to look at all the right things again, but they will add disability to their secondary outcomes. And recruitment is essentially a quarter of the way there, so look forward to that. Bottom line, TXA and isolated brain injury. JC would not do this, okay? Insufficient evidence. I would wait for the CRASH-3. It's going to come out in a few years, so let's hold off. Any questions for isolated TBIs or any comments? Okay, fantastic. Let's move on to epistaxis. So, you have a 24-year-old male, Mr. Meme, that presents with a spontaneous nosebleed. He swears he didn't pick his nose, and he swears he was just listening to a song when it just started bleeding all over the place. But you do not believe him. And in terms of the survey results, this is what came about. So it looks like there's a significantly higher proportion of residents that are willing to consider the use of tranexamic acid. Only 30% of them saying no, compared to closer to 70% in the staff. Current literature on this topic, mostly case reports and case series. So these are mostly in hematology clinics where they're treating their patients with hereditary hemorrhagic telangiectasia. So that's where a bulk of the anecdotal stuff comes from. There are no robust RCTs, but there are 2 randomized controlled trials to talk about, and you'll know about them today. The first we actually covered in Journal Club not that long ago. It's called A New and Rapid Method of Epistaxis Treatment Using Injectable Form of TXA Topically by Zahid and colleagues, published in AGEM in 2013. And what they did was they took, it was an RCT, single center, and they randomized 216 patients. These patients were somehow randomized to either receive TXA topically for this unknown amount of time, or receive anterior nasal packing. And that anterior nasal packing group got local, put in for 10 minutes, reassessed, and then got a rocket right up their nose. And so these patients are patients that presented to the emerge with ongoing epistaxis. What they ended up finding is that the frequency of epistaxis stopping at 10 minutes was higher, statistically significantly higher, in the TXA group than in the anterior nasal packing group. And rebleeding rates were lower when you used TXA as opposed to packing for 3 days with antibiotics and whatnot. And patients, there was a 95% discharge from emerge within 2 hours if you were in the tranexamic acid arm. And patients seemed to be more satisfied. So, limitations of this study. Sure, it's a very positive study, but really the patient selection was very unclear. It's very difficult to tell if they had any kind of pre-randomization interventions. Like, did they have nose clips in the waiting room? I don't know. And it wasn't blinded. The doctors knew what arm they were getting. And actually, the comparator was kind of unclear to me. As I told you, they received topical vasoconstrictors for 10 minutes, and then they took it out, they looked. If they were still bleeding, they got the Myrocel, and they failed. Okay? So bottom line, it's a methodologically weak study. The most you can say is that tranexamic acid may be an option. To be complete and for you to walk away with knowing all of the available RCTs in nosebleeds, there was this paper published called The Effect of Local Tranexamic Acid Gel in the Treatment of Epistaxis by Kaplan and colleagues, published in ORL in 1995. Now I'm just going to summarize it really quick because it's not a good paper. This was a study done in Sweden, or Switzerland, I think Sweden, across 3 clinics, and essentially they had no statistically significant results. The arrest and bleeding within 30 minutes actually was, they had a higher success of stopping with placebo than with TXA. But huge limitations, tiny studies, so around 64 patients. The aims and objectives are actually never stated in the paper. No evidence of any kind of power or sample size calculations. No explanation of their randomization method. I have no idea what they did. And the baseline characteristics were completely different. So does not add much to our talk whatsoever other than a few chuckles, okay? Bottom line for epistaxis, there is insufficient evidence at the moment to fully recommend it, but it's still cheap, it's still safe, and I think it's willing, and I don't expect any new studies to come up. It's not a sexy topic. I think we won't see anything for another several years. And a practical approach to use it would be getting your local, okay, running over to resus, getting a vial or an ampule, breaking it open, or just drawing up 5 cc's of TXA, so that's 500 milligrams. You can mix it in a basin and put in your gauze or your pledgets, whatever you want. Put it in the nose, clip it, and see how they do in 15 or 20 minutes. And this will help, and this is kind of the bridge between just basic mechanical pinching and packing it. Because I don't know what your experience was, but I've transferred 2 patients from urgent care to OBS after they vagaled on me with an anterior nasal packing. And I had to hand one over. I believe it was Joe Kozar. I don't know if he's here, but I had to hand one over. And it's kind of not really great, right? So give it a shot and see what happens. If I want to a few minutes, so okay, if TXA were available in urgent care, how many people would use it and give it a try? Raise your hand. Okay, now, no, keep it up, up. Good. Now, considering that it's not available in urgent care, and it's only available in recess, how many people find that to be a barrier and they will not use it? Okay, so easily, okay, there's just a lot of this, but it seems like it is a barrier, so it's something that we can, maybe accommodate. It doesn't need to be refrigerated, it's easy to store, so it's something we can talk about with the stocking guys. Anything, any comments, questions for epistaxis? On what? Yes, there were some. I did not read them. They were just really long and really old. But they work. It seems to work. But there were only maybe 1 or 2 studies that looked at TXA. The other ones were mostly aprotein, which is off the market, and aminocaproic acid. Yeah.
There are other things that can help stop bleeding nosebleeds as well. Sometimes Surgicel, the little mesh that you can apply directly onto a bleeding site. I find that quite effective. I'm not sure if there's any sort of comparison between that and tranexamic acid. So there are stuff within the nosebleed area that you can just cut up and just apply to the bleeding site, which you find quite effective as well.
Okay. No, that's a good thought. But that's so expensive, though. I don't know if it's worth it.
That's supposed to be for posterior bleeds.
Yeah, it is for posterior bleeds. I wouldn't, full seal for a bad anterior bleed would be quite pricey. No? Okay. If anything comes up at the end, we should have time. We're going to talk about GI bleeds now. Okay? Excited? So GI bleeds are a common emergency. Okay? And despite advancements in terms of management, including early endoscopy, PPIs, whatnot, mortality is still relatively high and unchanged. In upper GI bleeds, mortality is 10%. In lower GI bleeds, it's closer to 15%. And this was the case I gave to you in the survey. So, how old? 60-year-old man with PUD who comes in with melena, he's tachycardic, looking really, really pale. Would you add TXA? And this is a case that I've been faced with many times, and I've given TXA in a few cases in the ICU, and we're kind of throwing everything at them. Results were as followed. It's a bit all over the place. People are thinking about it, but they're not sure if they should give it. So let's explore the evidence a little bit. There is a Cochrane review from 2012 by Glute and colleagues looking at TXA in upper GI bleeds, not lower, upper. And they identified 7 RCTs that compared tranexamic acid to either placebo or some kind of anti-ulcer agent. And the total number of patients was about 1,900. Amongst these studies, really the quality wasn't that great, okay? Haddad scores of less than or equal to 3 in 5 of the studies. And as you can see, the bias chart, lots of yellows, lots of reds, not very fantastic. And the results showed a reduction in mortality compared to placebo or anti-ulcer agent with a risk ratio of 0.61 and a confidence interval between 0.42 and 0.89. So you can see in the figure at the bottom, it favored TXA. However, in a lot of the studies, there was a lot of missing data. And the authors of this review tried their best to get a hold of the primary authors to get the data sent. My understanding is they only got one of the missing data. All the other ones were not available. So they did a worst case analysis, like a worst case scenario where all the missing data died or whatever. And these were the results, okay, in terms of mortality. It stopped being significant if they made it a worst case scenario analysis. So we just do not know. There was no difference in rebleeding, there was no difference in surgery, and there was no difference in blood transfusions between the groups. And 3 trials reported adverse events, and there didn't seem to be any significant differences in thromboembolisms. Limitations: the study quality of the included studies are poor. The studies are really old. Only one study, which was done in 2003, was done at a time where good early source control and PPIs were the standard of care. All the other ones were before that, so not very applicable right now. Lots of potential biases, like it was crazy. Lots of post hoc exclusions, poor description of methods, not very good. And I did a search, and I found one other study, one other RCT that wasn't included. And I got really excited, but then I saw that it was done by Banyenko and colleagues in 2011. It was in Russian, so I could not read it. I forgot that my fiancée was Russian, so I did not ask her to read it. But I found a systematic review done by no one other than the Crash 2 people that published in the BMJ in 2014. And as you can see, it's the Banyenko one, the first one, and the results are just all over the place. So it's obvious that I didn't miss much. Okay? Bottom line, it may have benefited, but definitely needs further study. TXA is not referred to in any of the guidelines. So the NICE guidelines, the American guidelines, not even mentioned. In lower GI bleeds, there are literally no studies. Okay, 0 studies. So this poor cloud is going to bleed out because TXA has not been looked at. Studies to look forward to. The HALTED trial. Again, TXA in the treatment of gastrointestinal bleeds. Very similar to the CRASH 2 and the CRASH 3 design. RCT, multi-center, double-blind. They're looking to randomize 8,000 patients with significant acute upper and lower GI bleeds. And randomizing it TXA to placebo. Just note that the TXA doses will be higher in these patients. I think it's a total of 4 grams in 24 hours, as opposed to the 2. And they're about a quarter of the way there. Now, I suspect that this actually might be a negative study. So talking to Dr. Tinmouth from hematology and reading up a little bit on TXA and what experts say, they do not think it will benefit patients that have a point source of bleed. So GI bleeds are usually quite at a specific point. They may not benefit as well as this patient that has systemic endothelial damage. So it might be negative. Let's see. Bottom line, for tranexamic acid in GI bleeds, insufficient evidence, wait for the HALTED trial, hold off. I don't think I have time for questions just yet. Let's move on to our last topic of the day, menstrual bleeding. The case I gave you, poor woman that suffers from abnormal uterine bleeding, presents with heavy menstrual bleeding for the last 2 days. She's stable, you want to send her home, she's not pregnant. Would you give tranexamic acid? It seems like most people would give it or would consider giving it. And I kind of expected that, considering it's been approved for this indication and it's kind of been accepted. For the rest of this talk, I want you to assume no malignancy, no pregnancy, and no significant pelvic pathology. Now just note that significant pelvic pathology does include fibroids, but ultimately fibroids, you need some kind of surgery to properly control it. And standard of care, medical management in fibroids is treating symptoms. So if symptoms is bleeding, then you can apply these recommendations, such as TXA. So heavy menstrual bleeding affects 30% of women. And it's the most common complaint under the umbrella that is abnormal uterine bleeding. And the definition by the Society of OBGYN of Canada is excessive menstrual blood loss, which interferes with a woman's physical, social, emotional, and material quality of life. So it's a very holistic kind of definition. They used to have, all of these volumes and frequencies and pads. That's out the window. It's if it affects the patient, they have heavy menstrual bleeding. And they found that patients with heavy menstrual bleeding tend to have higher levels of TPA. So they have higher levels of this knife that promotes plasmin chewing up their clots. So if you remove that ability to activate plasminogen to plasmin, then maybe it'll help, and that's where TXA fits in. So we're just going to go over results. I'm not going to go over much of the literature, but it's been found to be effective in placebo-controlled trials with a 40 to 60% reduction in blood loss reported in the literature. There is a trend, but again, not a statistically significant difference, of increased patient-perceived improvement in their symptoms. Now, tranexamic acid, when compared to NSAIDs or progestins, have actually been found, or I should be more specific, luteal phase progestins, have been found to be superior. So TXA superior has been found to be superior to NSAIDs and progestins, and with no significant difference in side effects. And in terms of thromboembolism risk, the risk is very controversial and not evidence-based. There is no reported VTE occurring in studies for tranexamic acid and heavy menstrual bleeding, and women that were considered to be of increased risk of thromboembolism did not have more events, thromboembolic events, when on TXA. And the incidence of thromboembolism and tranexamic acid in a population-based study was similar to the spontaneous frequency in all women. So despite the lack of evidence, experts still recommend caution, and that's fair and understandable. The most commonly prescribed and studied regimen is 1 gram PO, so 2 tabs by mouth every 6 hours until the bleeding stops. And typically you want to give it the day before they start bleeding, and they continue it for 1 week or until the bleeding stops, whichever one comes first. One study did find a 4 gram loading dose PO, but once was enough, and found it to be effective. For more acute presentations where you're planning to admit them, it's less emergy and more gynae, but you can give 10 milligrams per kilo IV Q6 until it resolves. So recommendations as to when to give TXA. It's in patients with cyclic heavy menstrual bleeding. So if they have predictable menstrual bleeding, it's better for them. You can give it to the ones that don't, but it's because you ideally want to start it the day before their period, you can, it's ideal for it to be a cyclic patient, if that makes sense. Or in a patient that does not want or cannot tolerate hormonal therapy. So you can use TXA or NSAIDs in these patients, and again, TXA has been shown to be superior. Now note that if their complaint is also pain or dysmenorrhea, then TXA does not improve pain. So I would go for NSAIDs in those patients. In terms of patients with abnormal uterine bleeding, so their frequency is off, they're not regular, or they desire contraception, you can consider OCPs, progesterone depot, or IUDs. This is beyond the scope of this talk. Bottom line for TXA in menstruation, in heavy menstrual bleeding, there's a strong recommendation for its use. It has been shown to be effective, an effective therapy in these patients, and you would prescribe them 1 to 1.5 grams by mouth, 3 to 4 times a day. So I would do it. So let's wrap up the entire talk and see if we have some time for questions. We started a bit late. In terms of trauma, I truly believe that it's ready to be used. Give it to patients where they present within 3 hours of injury, and especially if you're planning to order a unit of packed cells. But again, your threshold should be lower than that. Okay, so if you suspect they will need blood, at some point you give it to them. Isolated traumatic brain injury, the evidence is not there yet, so hold off for now. Wait for the CRASH 3. Epistaxis, the evidence isn't strong. Try it next time before you go to packing and see if it works for you. And we'll see if we can get it stocked in urgent care. GI bleeds, not ready to be used. Wait for the halted trial, and we'll see if it comes out to be a positive study. And lastly, we just reviewed this again, 1 to 1.5 grams by mouth, 3 to 4 times a day, preferably 1 day before the period starts until the bleeding stops or within a week. My references. And I would like to thank Dr. Gatien for being my supervisor and meeting up with me frequently. Asim for, I don't think he's here right now, but for brainstorming with me and always being there for me, you know. And Dr. Tinmouth, the hematologist. Gabriel Sin, my pharmacy friend, great guy. Again, KDL and Dr. Wu for letting me know about this study, and KDL for going back into the data and doing it all over again. Helen Albert from the CRASH 3 trial, and my fiancée Veronica Yuriev. I realized I had to put her in here because I heard her humming that horrible song in the morning while she was getting ready, and I knew she heard way too much of this talk. So, and of course, all of you for being here and for filling out the surveys. And I will take any questions at this point. By the way, so I learned something else about epistaxis for this talk. I didn't know this. I don't know if you guys do, but in anime or Japanese cartoons, they artistically represent sexual arousal with profuse epistaxis. So I did not know that. Yeah, right? Okay, lots of people didn't know that. So I had to crop out the woman he was looking at. And as you can see, it's all in shapes of hearts and very, very profuse. Anyways, don't tell me you didn't learn anything today. Anything else? No? Okay. Well, thank you.